I'm Bill Bommer, and I am here in Toronto at the World Congress of Cardiology. And we're here presenting a number of topics. We've had a couple of papers, one on new valve type implants, the other is on the PCI and TAVR monitoring program that we do in the state of California. I represent both the University of California at Davis and the PCI campus program, which is a pilot program in the state of California looking at hospitals doing PCI that do not have on-site cardiac surgery as backup in those hospitals. I think we're all familiar with the fact that cardiac surgery volume has been going down steadily across the U.S., not only in all of the states, but in California as well. And so we're having to deal with hospitals that have lower and lower volume of CABG. In those situations, we often, in the state of California, require those hospitals to have CABG before they can have PCI operations in their hospital. Therefore, as hospital CABG volume goes down, we're having very low volume hospitals having to be supported just to continue their PCI program. So in California, we started a pilot program of 6 hospitals where there was PCI allowed for both elective and emergency PCI procedures, and there was no cardiac surgery in-house. There were obviously arrangements made for urgent transfer if that needed to be happen, but we now realize that emergent transfer to the operating room occurs in much less than 1% of cases undergoing PCI. That has changed tremendously over the last 20 years, and now it is allowing us to do PCI at hospitals that do not have on-site cardiac surgery. And the data we presented was looking at 2 areas. One is off-site monitoring, which is the standard review of the registry data. And of course, we use the NCDR data set for that, compared with on-site auditing. On-site auditing means we send an individual to the hospital to go through those medical records, cath records, etc. We also review with an interventionalist the actual angiographic views before the PCI and during the PCI. And what we found was that off-site monitoring is a very good tool for monitoring these registries, but the on-site monitoring produced 6 to 14 times greater number of miscodes that were seen in the data set and misrisk assessments. By misrisk, I mean where the data would suggest a higher or lower risk in the risk model that we use to predict mortality. And therefore, to keep the playing field level, we felt that reducing misrisk was certainly advantageous. Now, what we found that misrisk was often that an interventionalist might have overrated the severity of a stenosis or the complexity of it, and on reassessment, we felt that it was actually a lower risk for mortality in that case. We found that misrisks that upcoded the risk were just as common as lower code risks for that. So in general, it balances out, but we feel that on-site monitoring at a low level does offer a way of improving the coding accuracy and keeping the entire program more accurate when using this important outcome data to make long-term decisions related to both PCI and CABG programs in the state of California.